So historically, we've really used PCR for BCR-ABL as our main MRD marker in Philadelphia chromosome-positive ALL. There's multiple studies showing that this is very prognostic in this disease. So particularly, patients need to achieve a complete molecular response, ideally within about 3 months of therapy to have good outcomes. And there have been multiple publications on this. In fact, there was one large analysis. It was a combined analysis from multiple institutions looking at patients who achieved a complete molecular response in Ph-positive ALL by about 3 months into therapy, and asked the question, do they benefit from transplant or not? And there was no benefit to transplant in terms of overall survival, which is of course the most important endpoint. So the conclusion of that is that we can use this endpoint, MRD endpoint, to identify patients who may not need transplant in first remission, which was historically the standard of care in Ph-positive ALL. So now we use MRD to decide on transplant in Ph-positive ALL. I think now the next step is we have better MRD tests than the standard PCR for BCR-ABL. What we're using at our institution and in the US, which we have available, is a next generation sequencing assay for the immunoglobulin or T-cell receptor gene rearrangements, which is sensitive down to 1 × 10⁻⁶, so 1 out of 1,000,000 cells. And this looks at a different target than the PCR for BCR-ABL. It's looking at these gene rearrangements, and it suggests that it's actually more specific for the actual disease than PCR for BCR-ABL. So for example, there's about 20 to 30% of patients with Ph-positive ALL who still have persistent low-level PCR for BCR-ABL, but who are negative by this highly sensitive next-generation sequencing assay. And there's now data to suggest that these patients who have low-level PCR but are NGS-MRD negative have just as good outcomes as those patients who are PCR negative and NGS negative. So now at our institution, we've actually switched to, well, we use both, but we really rely primarily on the NGS-MRD assay. We still do check PCR for BCR-ABL, but we don't use it as much for treatment-related decisions. I would say the only way that the PCR is particularly helpful if we have it alongside the NGS-MRD is that I'd be very hesitant to stop a TKI in a patient with persistent low-level PCR, even if the patient is NGS-MRD negative. But otherwise, we're really deciding using the NGS-MRD assay for our treatment decisions such as transplant or CAR T cells, et cetera.